So for the next session, which is Oncology, Drugs and Hypertension, I'd first like to invite the chairpersons, Dr. Alan Almeida, Dr. Dilip Kripalani from Mumbai, Dr. Avinash Ignatius from Pune, and Dr. Manjusha Yadla from Hyderabad. For this talk, we have all the way from Cincinnati, Ohio, a Mumbai boy, Dr. Prakash Gudsoorkar, who's got a special interest in oncology, drugs and hypertension. He's already online.
So Dr. Alan Almeida is joining us, sir. Sir, please.
Yeah. Alan, you can start.
Yeah. Hi, sorry.
Prakash is online.
Yeah, Prakash is online. I can see him. Hi, Prakash. Well,
hello, sir.
Prakash is the leading light whom we exported, and he went via Canada and now landed up in Cincinnati, Ohio. And he's selected a niche for himself, where he's now gone into onco-nephrology. And I'm sure that you don't want to hear me. So I think we'll start off with Prakash's talk.
Kim, it's 1 p.m., right? Is it? What's the time, Prakash?
Prakash,
Actually, I miscalculated all my time when I was talking to Dr. Trivedi. And right now it is approaching 1 o'clock at night.
So
But-
special thanks to you for all that. Thanks.
But my excitement was to be more in-person talk and see everyone around and have a live discussion, which is a topic which is close to my heart. And we have so many hypertension experts here. So this would be a lively discussion, hopefully.
Thank you.
So I'm going to just pull up. I hope you can hear me clearly.
Yes.
I'm going to pull up my slides and let me know if there is any technical issue with that. Can you see my slides now?
yeah, we can see it.
Perfect. So I'm not going to waste too much time, and then I'll just kickstart the talk. So thank you so much, the organizing committee of this event, Dr. Khanna, Dr. Trivedi, and everyone, all my seniors, mentors there. Really excited to talk about this topic. No, I don't really have any conflict of interest related to this talk. These are my disclosures. These are the objectives, what I'm going to talk about. So we'll talk about a brief, just overview about the epidemiology of hypertension in patients with cancer. How cancer and hypertension, they share a cause and effect relationship. We'll identify some salient contributors to hypertension in patients with cancers and survivors. We'll specifically talk about certain specific drugs. And in the previous discussion, so many of you have already highlighted those specific agents, and we'll talk a bit in details about them. And then just try to have it's not a consensus, but just an outline as to how to monitor these patients and how to strategize the treatment for these patients. So I'm just going to pull up some data which is more US centric. And this is more of an updated data from the cancer.org, which just shows the estimation of the burden of the cancer which is present at present. So the most important leading cause of leading cancer in males is obviously prostate. Females, it is breast. But what I want you to draw your attention is to the second figure. So you see the trends in the cancer incidence. So actually, if we were back in 1980s and we were still doing the same things as what we were doing in 1980s, the trends would have been following the red line, which just goes upward in an exponential way. But with the advent of the new diagnostics, cancer targeted therapies, screening, surveillance, everything, we are able to avert several thousands of deaths, but at the cost of the increased survivorship, which is good. But we are now facing the increased burden of cardiovascular morbidity, mortality, as well as, most importantly, hypertension. But I also wanted to bring up this data from the Indian Cancer Registry or the National Cancer Registry program. The current cancer incidence is 1.4 million. Most common cause of cancer, I mean, in males, or cause of death in males is lung cancer. In females, still breast cancer. But over till 2025, there is going to be 12.8, close to 13% rise in the incidence of incidence of cancer itself. And resultantly, we are going to see an increased number of other chronic conditions, which is similar analogy to what happened in HIV. HIV used to be a big killer, and then with the advent of new therapies, the chronicity and the chronic conditions associated with that. So similar thing is probably going to happen with the cancer, or is happening with the cancer. So let's build up a case as to why really this is important, and let's look at some prior studies which have been conducted in this. So what I'm going to show you is a childhood cancer study which comes from 3 or 4 centers, one of them being the St. Jude's, the Children's Hospital in Seattle, and the University of Calgary. So it included 10,000 childhood cancer survivors. And what they essentially looked at, by the age of 45, and these kids or children who have survived cancer are being followed, there is an increased incidence of coronary artery disease, hypertension, valvular heart disease, and arrhythmias. And one of the common risk factors which was observed in all these was incidence of hypertension. And as you really follow these patients till the age of 45, patients who were treated with radiation therapy and those patients who got anthracyclines as their cancer chemotherapy. Now, bear it in mind that most of these kids who have been receiving anthracyclines may have had acute leukemia as their initial diagnosis. But you can see the incidence of the cumulative incidence of the cardiovascular disease per se significantly goes up. Now we'll talk about in adults. So this was a retrospective study which featured in 2013, which looked at patients with solid organ malignancy. What they looked at was the incidence of hypertension in them. So when these patients were followed, 30% of these patients did develop hypertension, and the median time to onset of hypertension was 96 days after the first cancer diagnosis. So they looked at what are the predictors of hypertension in these patients. So they found certain cancer-specific predictors are there, that is kidney cancer, underlying bladder cancer, and gynecological cancer. These are the cancer types. And the therapies also determined. So cytotoxic therapies, targeted therapies, or a combination of these therapies were predictors of developing hypertension. So how do we strategize? How do we prioritize these things? So in the early stages, when the patient is being treated for the cancer, the focus is always on curing the cancer or getting control over the cancer. But as the patient survives and as the years pass, the focus shifts over to more managing the chronic condition, and most importantly, hypertension in this context. And survivorship essentially begins. It doesn't mean that the patient is cured and then the survivorship begins. Survivorship stands, it basically starts when the patient is diagnosed to have cancer and when patients initiate on therapies. So how is cancer, hypertension, cardiovascular disease, and chronic kidney disease, everything interrelated? And it is a more of a multidimensional relationship. So we all know smoking, diabetes, and obesity are important risk factors. We all know smoking and obesity are independent risk factors for cancer itself, which predisposes to cancer, which predisposes to hypertension, kidney disease, and heart disease. So this is just like a vicious cycle or a multidimensional relationship between all these entities. So now I just want to drive your attention to anti-cancer therapies and what the impact is on blood pressure. So this is a busy slide, and I really apologize for that if you're not able to see it clearly. But what I want to drive your attention here is go back to 2001, when there was only a single agent, that is your imatinib, which was approved for treatment for CML, which was a targeted therapy. But then as years passed by till 2020, there has been a boom in these agents. I mean, most of these agents, I don't even know how to pronounce them most of the times. I have to go back before I see a patient to try to rehearse how to pronounce these drugs, because patients always know what they're getting. So there has been an increased number of these alternatives and MABs and all those agents. So it's always important for a nephrologist to understand what the driving mechanism or the basic mechanism or what the class effect of these drugs is. So when we talk about hypertension, we all talk about the US or the American Heart Association guidelines. We talk about the European Heart Association. We talk about the NICE guidelines. But when the cancer therapies are being administered, and when the National Cancer Institute, when they study these clinical trials, they look at what they called as the adverse events in the cancer criteria, which categorizes the hypertension in 5 grades. And these 5 grades of hypertension may not always equate to our existing hypertension guidelines. So we really see, so the places where you see not applicable is where our knowledge gaps are. So we really don't know yet, should we use the same guidelines as what we have been using in a non-cancer patient to determine the goals and the targets for the therapies. And this research is in progress, and hopefully we will have some answers. We are also working on a position statement where we can have a consensus amongst not just onconephrologists, but nephrologists who manage these conditions, to have some consensus guidelines as to how we set up targets for patients who are being treated for cancer. So this cartoon actually just shows various drugs and various mechanisms by which certain chemotherapeutic agents, be it conventional or certain targeted therapeutic agents, cause hypertension. So Vinca alkaloids, they induce autonomic neuropathy, they cause hypertension. Agents like vascular endothelial growth factor, Burton kinase inhibitors, even gemcitabine for that matter, it causes vascular injury and produces hypertension. So there are certain agents like anti-androgen agents, glucocorticoids, which are administered. It causes sodium retention. So various mechanisms operate, and some of the drugs may operate through multiple mechanisms. So it's important for us to understand what mechanistic pathway these drugs are causing to induce hypertension. So now coming to the elephant in the room, the vascular endothelial growth factor. My talk is going to be concentrated more specifically on this particular agent, and I heard the questions which were being asked by several attendees there about treatment with various tyrosine kinase inhibitors or Avastin. Somebody brought up bevacizumab. So I'm going to address those same issues in my few slides from now on. So vascular endothelial growth factor inhibitors, they have really changed the paradigm of treatment of so many cancers. They are being used in thyroid, brain cancers like glioblastoma, renal cell cancer, colon cancer. Actually, Avastin was FDA approved back in 2003, 2004 for treatment for metastatic colorectal cancer, then liver cancer and gynecological. So you name it, all cancers, there is some protocol somewhere where they are either treated with immune checkpoint inhibitor or a vascular endothelial growth factor, or maybe a combination of these agents. And when clinical trial data was being published, it was evident that the hypertension incidence was between 20 to 90% in these patients, which is a big range and it's a big burden. And a meta-analysis which was published from the Eurocancer data, close to 29,000 patients which were there in that, they looked at the tyrosine kinase inhibitor induced hypertension. The relative risk for developing hypertension was 3.78 compared to placebo. So that's a big burden. So whenever I talk to even my trainees or other nephrologists about approach to hypertension, I like to bring up a few prototype cases, which are more of the real cases which I have encountered in my practice. So let's talk about the first case, which is a tyrosine kinase inhibitor induced hypertension. So this was a 60-year-old female who was being treated for gastrointestinal stromal tumor, was treated with sunitinib. Nephrology was consulted because of new onset hypertension and proteinuria. Blood pressure shot up to 170 over 100. Creatinine was reasonably preserved. Urine analysis showed +4 of protein on dipstick. There were no RBCs, so nothing like a nephritic picture. A 24-hour urine protein was done, which showed 3.5 grams of protein. Now, I think everybody in the room will agree that whenever safe, this patient needs to proceed with a kidney biopsy. There was fortunately no evidence of peripheral hemolysis, so platelet function was well preserved. There was nothing to suspect a systemic TMA or a TTP-like pattern happening here. But we did proceed with the biopsy after adequately controlling the blood pressure. And this is what the biopsy showed. So now, in the constant of the time, I'm just going to run down the pathological image. It basically showed somehow my arrows did not pop up here. I'm sorry for that. But if you can see the pointer, you can appreciate the fibrin deposits which are there in the kidney, and that's quite florid fibrin deposition. You can also see the endothelial swelling here, and you can see the concentric hypertrophy of these arterioles. So this is a very classic injury of thrombotic microangiopathy, per se, a renal limited thrombotic microangiopathy, which can happen in patients who get treated with sunitinib, which is a tyrosine kinase inhibitor. So what was done? We started the patient on lisinopril. Fortunately for this patient, the cancer was well controlled. So the oncologist was bold enough to stop sunitinib, and the 24-hour protein, after that, it decreased to 0.5 grams. Patient unfortunately expired around a year ago because of the progression of cancer, and there were no basically developed metastatic disease. But at least for 2 years, we could keep her, give her a good quality of life. So the proteinuria reasonably came down. Another set of patients which I see very commonly in my practice is just probably because of our neuro-oncology division, and that feeds a lot of patients to me, especially patients who are being treated with all these newer agents, that is bevacizumab. And the sad part of the story is that most of these patients are so young, so productive in their life. So I know somebody brought up a question, how do we manage between the oncology and nephrology? When do we stop the drug? Let's talk about those things here. So we have 3 patients who range between 30 to 40 years who have been diagnosed to have glioblastoma, are treated with Avastin. So patient 1 is a new onset hypertension and develops proteinuria with very well preserved renal function. Patient 2 develops new onset hypertension but no proteinuria. And patient 3 has a pre-existing hypertension, and now the hypertension is being worsened. So these are the typical scenarios which I encounter. The common thing which I face is the first one, the new onset hypertension and proteinuria. So how soon proteinuria can develop and hypertension can develop after VEGF inhibitor? 55. So this is a case in which a 55-year-old female was treated for recurrent meningioma. She was not a surgical candidate. First dose of Avastin, within a week, blood pressure shot up to 190 over 120 and had dipstick proteinuria, and the 24-hour urine protein was 2.1 grams. Another case, 48-year-old male who was treated for grade 2 WHO grading of oligodendroglioma, not a surgical candidate. First dose of Avastin, blood pressure shot up to 160 over 100. So these are very distinct cases which I have seen in the practice, which probably were like first dose effect. One dose, within a week to 10 days, you see this florid presentation with significant proteinuria and hypertension. Looking at some clinical trial data, which I have already mentioned about, that these 2 drugs which really stand out, the sorafenib and the Sadiranib, is in one study, it showed 93% of these patients develop elevation of blood pressure by sixth day of treatment. And 67 of the patients had persistent blood pressure elevation. And nearly 43% of these patients had grade 3 hypertension. Like patients also presented with hypertension crisis. So pretty much a notorious drug to cause hypertension. So how does these agents, both these tyrosine kinase inhibitors and Avastin, how does it cause hypertension? So it is more of a class effect. So all these agents, they act somewhere on the VEGF pathway. It could act on the VEGF A, VEGF C, VEGF D, or it could directly block the VEGF receptor. So if you look at the downstream pathway of these agents, they typically reduce the endogenous nitric oxide. They increase the endothelin levels. Endothelin is a natural vasoconstrictor. It also increases the systemic vascular resistance. It can also cause podocyte damage and cause endothelial rarefaction, thereby causing an endothelial dysfunction, plus podocyte injury, protein leaking, hypertension, and it's just a vicious cycle. And endothelial, this is more on in the mice model. Endothelial rarefaction can happen as early as 7 to 14 days after the treatment with any of these agents. So, which kind of proves the concept with the previous two patients which I showed, who presented with hypertension within a week to 10 days of the therapy. Now, these are more of again mice model, experimental models, but how does really the hypertension happen at the tubular or the nephron level? So it's a very interesting concept which even I recently learned, was the sodium chloride co-transporter on the distal convoluted tubule and the ENaC channels. They actually share a close association with the vascular endothelial growth factor receptor 2, so that they are very in close proximity. So whenever these receptors are blocked, it somehow blocks these other receptors also, which actually causes the sodium reabsorption, and there is decrease in urinary sodium excretion, thereby causing the blood pressure to go up. More of a mice model experiment, no human studies to back this yet. But if you look at in general the table, if you look at all these drugs acting at various pathways, like I showed, the incidence could be anywhere from 40. In certain drugs like cabozantinib, it could be 30 to 60%, and lenvatinib 70%. So very important drug class effect of hypertension in these. How do you really treat patients who develop VEGF inhibitor induced hypertension? So now there is no real data to support which drug is better. But what we always do is we already try to extrapolate all our data from the diabetic nephropathy or glomerular disease world and try to use it here. So if there is a podocyte damage, what we are talking about, why not use RAS inhibitors? And RAS inhibitors do help in controlling the proteinuria as well as the hypertension. Calcium channel blockers like the dihydropyridines, especially nifedipine, amlodipine, can be used. They are smooth muscle relaxants, as well as they enhance the vasodilatation, especially to counteract the vasoconstriction which is happening from the endothelin. Long-acting nitrates have also been used. You give nitrates, it ramps up the endogenous nitric oxide production, thereby causing mitigation of the endothelium-induced vasoconstriction. So what should we not do? Not to use the non-dihydropyridine calcium channel blockers, because these are enzyme inhibitors. It just messes with the drug, the cancer drug. Per se, diuretics are not contraindicated. I do use diuretics occasionally, but you have to always be cautious, especially with the patient's nausea, vomiting, and volume depletion like scenario. Just be careful. Per se, no, not contraindicated. Previously, when I mentioned that there is no data to support, no particular robust study to support the use of RAS inhibitors. This study, this is a very small study which was conducted out of Vanderbilt University, and they presented this data at the American College of Cardiology conference when they looked at RAS inhibitors in reducing systolic as well as the diastolic blood pressure in patients who were treated with VEGF inhibitor, and did show decrease in the blood pressures in the patients who were treated with RAS blockers. So yes, there is a benefit. Do we have enough data to support that yet? No, but this is the best thing what we have for now. So this is a more of a concept map what we had constructed for one of our review articles, and it is just a mental checklist, not a perfect thing to do, but try to go through a checklist, try to do some risk assessment, like what we usually do for hypertensive patients. Risk assessment, look for the cardiovascular burden, pre-treatment labs, make sure you get a kidney function test, check urine protein, check urine analysis, measure the baseline blood pressure, try to stratify where they really fall into, whether they are high risk, high normal, if they have pre-existing hypertension. And when they develop hypertension, do encourage them to monitor their blood pressure at home, which is easy to say than really do. Ambulatory blood pressure monitoring always helps. We don't have the luxury of doing that. It's not reimbursed by the CMS, so it's very difficult to get it. But this is how I approach these patients, is to start them with ACE inhibitors, ARBs, or calcium channel blockers if they are not already on. If the blood pressure is not controlled, add in second agents like beta blockers, mineralocorticoid antagonist, diuretics. And if still the blood pressure is not if the blood pressure is not controlled, we go into this box where the discussion with the oncologist really helps. Now, if a person is a young person with a cancer like glioblastoma, but is dependent on Avastin for the therapy, and that's the only drug which is available, then the real-time discussion has to be there between you, patient, and the nephrologist as to what are the risks of topping the drug, because that may just kill the patient. So with adequate RAS blockade and all the antihypertensive agents, we try to control the blood pressure. I have a patient who is a 30-year-old executive, bank executive, who has glioblastoma, and he is non-operable, but doing excellent, but has 3 grams of protein. So we just continue the drug, adequately manage, and just pray. So what are other targeted cancer therapies we have which can induce hypertension? And this, I just given you a list because I didn't want to go into details about all these drugs because it just opens up a Pandora's box. But a few agents like the Burton kinase inhibitor, that is the ibrutinib, which is being used in the CML, mTOR inhibitors, sirolimus, everolimus. Important to address is the proteasome inhibitor. Sorry, I'm just going to pull up the incidence of hypertension here with each of these agents. Proteasome inhibitors, which have become the frontline therapies for multiple myeloma. The bortezomib and the carfilzomib, the clinical trial data actually showed 15 to 25% incidence of hypertension, with through various mechanisms. It could be probably direct endothelial toxicity. So these are just some newer targeted therapies or targeted agents which are being used, which have a pro-hypertensive mechanism. Just to summarize what we have done so far, we have seen a few molecular targeted therapies, the VEGF being the most important one here. It induces hypertension. It is important to recognize it early and treat appropriately. And the final downstream pathway for most of these agents is endothelial dysfunction and podocyte injury. I'm just going to briefly highlight, though it is not a drug, but I just wanted to highlight hypertension from radiation because sometimes I do see these patients coming to the clinic. But this was more of a patient whom we saw in the hospital, a 48-year-old, not a hypertensive female, underwent a total abdominal hysterectomy for adenocarcinoma of fallopian tube. Pre-op creatinine and urine analysis were fine. Post-operatively underwent radiation therapy for 8 weeks. And after 12 weeks of completion of the therapy, patient developed blood pressure rise to 190 over 120 systolic and diastolic, blurring of visions, proteinuria, and severe AKI, more so presented with a hypertensive crisis. Ultrasound did not show any obstruction. CT abdomen did not show any cancer recurrence. So what was the diagnosis here? So what we did is we quantified the proteinuria. Patient had 2.8 grams. Patient had microscopic hematuria. Hemoglobin was 7. Patient had cystocytes, low hapto, and high LDH. And for the audience here, it is a no-brainer. This probably sounds like a thrombotic microangiopathy-like picture, or probably a systemic TMA or a TTP-like picture. Fortunately, the platelet count was not too low. We went ahead boldly with a kidney biopsy, and kidney biopsy did show significant concentric, like the typical onion peel appearance of the arteriole, and thrombotic microangiopathy. And it showed severe endothelial injury, endotheliosis, which is classically described in pre-eclamptic state as well. So the similar analogy was seen here. So what we did, we aggressively managed the patient's blood pressure. Creatinine did come down with the blood pressure management in 6 weeks to 450 milligrams. The peripheral TMA did resolve. She did have some residual thrombocytopenia. But always I like to send, whenever there is a suspicion for TMA-like process, we always send for a workup for atypical HUS upfront. You never know whether these patients may have an underlying genetic predisposition, and things like radiation therapy or even Avastin or these tyrosine kinase inhibitors could act as a second hit to these patients and cause the cascade activation for the complement breakdown, causing thrombotic microangiopathy. So this was a very prototype case which we saw a year ago with radiation-induced hypertension. But when you talk about radiation and hypertension and kidney disease, it's basically a spectrum of injury which happens, which can happen as an acute radiation nephritis, which presents with severe interstitial inflammation and acute tubular injury. Hypertension can present as malignant hypertension. And it all depends on the timeline from the radiation exposure. But malignant hypertension could present even after 12 to 18 months after the radiation has been given. So it's important to understand where in timeline the radiation was given and when did the hypertension really start. Just a few considerations, and I'm just coming to the end of my talk. So just a few considerations in management of hypertension in patients with cancer. Beware about white coat hypertension and masked hypertension in these patients. This is a very sick population. They are extremely worried. Many of them, they don't have jobs. So white coat hypertension is a big thing. Bone and neuropathic pain, stress, these all contribute. Adjuvant therapies, important to pay attention because they are pro-hypertensive. Accurate blood pressure management is very important. Always ask the patients to monitor the blood pressure at home. And if you can get an ambulatory blood pressure monitoring, well and good. And avoid RAS inhibitors especially on the days when they are sick. I tell them to stop it for 2-3 days if they're throwing up or they are having diarrhea or feeling nauseated, just to avoid any hospitalization with AKI. What are we looking at beyond the horizon? What more needs to be done? So we need to define hypertension and its targets for this very specific population. We need more data on the cardiovascular outcomes. Most of the data has been retrospective, which I outlined previously. We need some prospective studies on that. Childhood hypertension and an adult survivorship program is very important. Actually, we have started the survivorship clinic where from the Children's Hospital, the patients get, when they graduate, they become 18 years, they get transitioned to our care. So there are very specific things which need to be seen from adult, pediatric to adult transition. Then we need to have certain consensus guidelines as to how effectively manage. We know RAS inhibitors we can use, calcium channel blockers, when to biopsy, when not to biopsy, what are the bleeding risks with these biopsies. So we need a position statement on these things as to address, just to provide everyone a rough guidance as to what to do and what not to do. These are the two institutes which are closely associated with our university, the Barrett Cancer Center, the UC Gardner Center, Neurosciences Center, which I get most of my patients from. Just to give you some resources, recently we published 2 back-to-back issues on onconephrology. We have a few authors probably sitting there in the audience, and It was very well received. It's an excellent compilation of close to 25 manuscripts, and nearly 70 plus authors really contributed to that. And let me know if you need probably not everyone does have an access to this journal in India. So if you need, just send out a message to me on Twitter, or you can take my phone number, text me. I can share all the articles to you. And what Shruti Gupta mentioned about join ASO, and a very active group. A lot of discussion happens. We have a chat group, WhatsApp chat group, where we post questions. A lot of discussions happen on them. Journal of Onconephrology, which is an upcoming journal, and which publishes peer-reviewed manuscripts specifically on onconephrology. This is just recently published, maybe 2 months ago. You can go through that scientific statement as well. And thank you so much for the patient hearing, and I'm happy to take questions and try to answer them.
Thank you, Dr. Prakash. It was an excellent talk. Excellent talk. Good to hear on such an interesting topic. Of course, not much of exposure to most of us. But then, as you said, how to define cancer-related hypertension, what are the targets that are yet to be known. As you said, there's been a recent publication in the journal Hypertension by the AHA, the scientific statement, though we are yet not clear how to define hypertension secondary due to the cancer drug, and of course the targets. What we need the most important is the focus is on the oncologist referring the patients before the initiation of the therapy, as to just not evaluating the creatinine alone, but then if hypertension is there, referral to us, and if proteinuria is there, referral to the nephrologist. I think that area should be strengthened. What I mean to say is a pre-initiation of the cancer therapy should be one of the areas which needs to be strengthened. And of course, during the cancer therapy, if the patient develops hypertension, proteinuria, as to how to go about it, as you said in one of the patients, you had to stop the chemotherapeutic drugs because of the development of hypertension. Does it happen always? Is it the only way that we can overcome the severe hypertension apart from the usage of the drugs, or probably severe proteinuria sets in? Do we need to stop the drugs when the patient is on the course of the therapy? The other area of focus needs to be post-chemotherapy, especially with the drugs such as, which are related to the platinum drugs, such as cisplatin, which are known to be there in the blood for such a long time. The long-term implications of the usage of the cancer drugs with respect to just not the hypertension, but then the cardiovascular events as well. So these are the areas, if you can just put in your thoughts as well on this.
Definitely. So taking your first comment on the oncologist should involve a nephrologist beforehand and prime us. I have been struggling to convince them these things, which is extremely difficult. It took 2 years for me to convince them that, hey, I am interested in pursuing this specialty. You send me patients and we can co-manage them. So it was a very hard sell. It is getting better now. Sending it to you or a nephrologist beforehand is still going to be a hard sell for it seems. But ideally, that should be the case scenario where I mentioned about the checklist. It should be done before the therapy to risk stratify these patients. Yeah.
See, other thing is during the surgery and during the chemotherapy and post-chemotherapy, what should be the surveillance and all this?
So what I do is during so these patients, especially on tyrosine kinase inhibitors and Avastin, I see these patients every month. They come for infusions every 2 weeks. I see them every month with a set of labs, with a set of urine analysis and a urine protein to creatinine ratio. And there is a very low threshold for the nurses on the oncology division to call me with the surges in the blood pressure. Because what happens is the patient comes to the infusion unit while having the infusions for the targeted therapy. And invariably, the blood pressure is 160, 170 systolic while the patient is there in the hospital. So they get worried and they don't land up not giving the infusion. So sometimes more of a reassurance is very important at that point of time. Or what they do sometimes is they just randomly give a hypertensive agent, say a clonidine spot dose or one dose of lisinopril. So there should be some protocol. So I have advised them not to worry, given them some blood pressure targets, when to treat, when not to treat. Yes, if it is 180 systolic and above persistently during the infusion, I tell them to stop the infusion. Again, these are just opinions, and there is no hard evidence to support what I'm talking about yet. Hopefully, we should have some evidence for that. And this is more of during the infusion or actively being managed patient. But those patients who have finished their therapy, so I have a few patients who have really completed their therapies and the cancer is in remission. I typically follow them every 3 to 4 months if they are very significantly proteinuric, or maybe once in 6 months. But I always have my phone. I'm on hot call with any of the oncologists in my division. They just send me a message, and then I try to accommodate them sooner in my clinic.
Dilip, your thoughts? Yeah.
Thank you. Dr. Prakash, thank you. Excellent talk. I've seen a couple of patients with Avastin-induced hypertension, which can often be very labile. So when they're off their chemo cycles, I've seen patients when they're on the cycle, they need 5 drugs, 5 agents to control their blood pressure. And I'm talking of patients who've never had hypertension or any kidney disease before, new onset hypertension. And when they are off the cycle, their requirement of medicines comes down. So this is a very important thought. I thought I'll take your take on this. How closely do you need to monitor them, and how do you, which drug do you take off first, and how often do you want to monitor them? Do you put them in hospital, because they could suddenly go into hypotension? So how do you manage this sort of clinical scenario?
Excellent question, and a very, very practical thing which you have asked. And I do encounter these things. Fortunately, I have had a patient with a labile hypertension who is on lisinopril, spironolactone, nitrate, beta blocker. And what I usually do is I try to keep them when the blood pressure has been tanking down. So you're right. So what happens is, as the drug effect goes off over 2 weeks, when they're due for their next infusion, the blood pressure starts to go down. When they get the dose, again, the blood pressure starts going up. Now, there is a lot of variation in this response. And I've spoken with my pharmacist, and they don't really have a definitive answer, because it all depends on how the cancer is responding, what the penetration of the drug into the cancer. So the bioavailability of the drug fluctuates quite a lot. But if I were to, so what I have done in that particular patient is stop the nitrate, stop the calcium channel blocker, keep them on an MRA and the lisinopril, and then gradually add. Patients is given specific instructions to add that drug based on the home readings.
Yeah, so my advice to my patients here is that they should be monitoring at least 2 times a day at home, daily. And that I actually give them cutoffs, and I tell them omit your CCB, being primarily the most powerful drug, if your BP is below this, and then I keep them on a very close follow-up. Thank you.
We'll request Avinash for his closing remarks. Yeah.
Yeah, a very insightful talk, Dr. Prakash. Just a thought here that I think we need to send this message to especially our oncology friends, is that hypertension is also a marker of kidney injury, and not just wait for proteinuria. And especially in the specialty where significant weight loss can happen over a period of weeks. And today we are looking at EGFR, which are not weight-based. So looking at a reported EGFR can be a falsely marker that everything is fine, whereas actually a person has lost a lot of muscle mass and his creatinine remaining stable can be an underlying progression of CKD, which we don't pick up. So probably this worsening hypertension as a message that it is kidney injury, and it's not our cardiology colleagues may not be happy with that it's renovascular and not cardiovascular. So, but I think that message might help a little getting a focus onto the kidneys.
Absolutely, absolutely. So in fact, a lot has been published by the cardio-oncologist in this area, but not by onco-nephrologist in this area. So we are trying to push the boundary for that.
Thank you very much, chairpersons. And thanks a lot, Prakash, for that talk.
Absolutely. My pleasure. Thank you so much.